Okay. Now, thank you very much, everybody, and welcome to join this workshop on developing an integrated module for health professions education. The format would be that this would be a presentation, but during the presentation, we would have a few small individual activities. And at the end, we will have a group activity where I have already WhatsApp you, the two groups and the tasks, and we would work on that. And then there would be a presentation and discussion. However, you can stop me anytime during this presentation or discussion, and if you want to clarify any point. And it would be good if we can have a two-way communication rather than only one-way communication. Is that okay?
Perfect, sir.
Right. Okay. Sure. Now let's see the first point here is the steps of designing and implementing an integrated curriculum. There are 5 steps, and the first one is identifying the learning outcomes. Whatever module we want to have, we must try first to identify learning outcome. It may not be easy, and sometimes we have to go up and down based on the content, and we look at the learning outcome again, and we look at the content again, and then we find the right learning outcomes. Once we have these learning outcomes, then they play a major role. They help us, they guide us to identify the content. Also, the teaching methods and assessment methods would be based on the type of learning outcomes. If learning outcome says able to perform, then the teaching should be a practical method of teaching, and same should be the assessment. And this is what we call is constructive alignment, that learning outcomes help to identify content, the teaching method, and assessment method. So all these subsequent steps follow what is required by the learning outcome. So they play a major role. So the second step is a teaching plan or sequence of delivering the identified content, which is mainly the timetabling. The third step is implementation and monitoring of teaching activities, which involves teaching approaches and methods, preparation of teaching materials and resources. Fourth step is implementation and monitoring of assessment process, which includes assessment approaches and methods, preparation of questions, exam materials, conduct of examination, and compilation of results. And finally is improving teaching and assessment based on experience and feedback. If you see the first 2 points I have highlighted in red because that's the area we would be covering in today's session in detail. Right, so having that background or the understanding those 5 steps, based on that, the learning outcomes of this workshop itself. So after attending this workshop, the participants will be able to, number 1, explain the principles of integration in the curriculum and how these principles influence in developing an integrated curriculum. Second, discuss different levels of integration in the curriculum and see how these levels impact on developing an integrated curriculum. Thirdly, explain the process of developing an integrated curriculum. Fourth, develop an integrated module. May not be complete, but to a great extent. and manage common challenges in developing integrated modules. So these are the 5 learning outcomes which we will, inshallah, achieve in today's workshop. So let's start with refreshing our concepts about the integrated curriculum. Here is an old but quite comprehensive definition. A fully synchronous, or in actual time, transdisciplinary delivery of information between basic sciences and clinical sciences through all the 5 years of a medical school curriculum. So it's the real-time transdisciplinary delivery of information which combines the basic sciences with the clinical sciences, and it has to be all the 5 years or 6 years of the curriculum of a medical school. Means it starts from the year 1 and continues till the final year of the MBBS program. The second definition, which is more of operational or practical definition, the organization of teaching matter to interrelate or unify subjects frequently taught in separate academic courses or departments. So this is basically whatever content we have identified, we have to organize it in such a way that it interrelates and unifies subjects from different departments. And a third definition, the teaching different subjects in a thematic manner. And this is one area which we would be going quite into detail during today's workshop. Teaching different subjects in a thematic manner means different subjects would be taught under themes. However, the emphasis would be on the topic, on the theme, and not on the disciplines. And we'll see how we can achieve that. Here is a definition, quite old again, by General Medical Council. And it says that we strongly favor true integration of the course, both horizontal and vertical, using the term in the sense of interdisciplinary synthesis and not simply coordination or synchronization of departmentally based components. So there are quite a number of terms, medical education terms used in definition. For example, horizontal and vertical, interdisciplinary, coordination or synchronization. So these terms would be clear shortly when we look at the next few slides. Right, now the first term here is horizontal and vertical. So let's look at this concept of horizontal and vertical integration. If you see these arrows, so in basic sciences and in clinical sciences, horizontal integration means integration between the disciplines or subjects which are taught in the same phase. For example, integration among the subjects taught in the basic sciences, phase 1 is horizontal integration. Similarly, if there is an integration among clinical subjects only, that would be again horizontal integration. But vertical integration means that there is integration between 2 phases. Phase 1, phase 2, preclinical or clinical, basic sciences, and are clinical. So that's the difference between horizontal integration and vertical integration. But important here is look at this diagonal line here. It never touches 0. Means that there would be some degree of clinical input even from the very beginning of the course, and basic sciences would be continued being taught till the final year. Of course, the initial clinical input would be small, but it would increase along the time, whereas the initial input of basic sciences would be more in the teaching, and but it would the later on would be less in teaching, but it would still be there. So that's the concept of horizontal integration, vertical integration. When we say vertical integration, it also includes horizontal integration, right? So this has been explained in this, that horizontal integration is information taught in the same curricular phase, that's a preclinical or phase 1, is taught together, usually focused around a theme or a problem. Whereas vertical integration, information taught in different curricular phases, is taught together, usually focused around a clinical theme. So that is the concept of horizontal integration and vertical integration. And to have this concept clear is important for us when we are developing an integrated module. Right now, here is a short activity. Let's see if we can do that. Okay. Can you see this slide? Is Dr. Adnan Khalid, can you see this which says integrated curriculum?
Yes, we can
Yes,
see
sir, we
it.
are seeing it. I can see it now.
Okay, now there are two methods. Either you can scan this QR code and then answer the questions. Other ways, you can go to this website menti.com and then use this code, and then you can enter your answers. Let's see, it's a small interactive activity. Right. So yes, the integrated curriculum breaks barriers between disciplines, right? That's the major sort of attributes of integrated curriculum, that it combines the disciplines. Number 2, encourages application of basic sciences knowledge in clinical situation. Yes, absolutely true. It encourages even in the preclinical years to connect with the clinical years. It's best illustrated as horizontal integration in basic sciences No, we actually want an integrated curriculum, the vertical integration. So it would be best illustrated as a vertical integration rather than the basic sciences. And then is best imported when teaching is organized under themes. Yes, absolutely right. And demands early inclusion of clinical experience in the curriculum. Yes, absolutely right. Right. So the only this one is not correct answer, that we are not aiming only at horizontal integration. We are aiming at vertical integration. Right. Thank you for taking part in this small activity. Let's resume to our session. Right. So that's what we wanted to actually you can see this slide, right? Saying Mentimeter. Yeah, right.
Yeah.
So that small activity was meant to really clear our concept, and so that all of us are on the same page, same understanding, so that when we move further, we know that we are talking in the same language. Right. Now, let's look at the 5 principles of integration, and we will see how these principles influence on our exercise of developing a integrated curriculum. The 5 principles focus on key areas: construction of knowledge, application of knowledge, critical thinking, and staff development. I'll go into a bit detail. The first principle of integration. Yes, Dr. Khalid, please.
Yes, sir. First of all, sir, thank you so much for organizing this workshop for us. There's one confusion regarding the definition of the word theme.
Right.
So if you can actually exemplify the definition,
Um,
is so
okay,
that
okay.
would clear a lot of
Dr.
things.
Khalid, if you wait a little bit, there would be lots of examples.
Right, sir. Thank
Right.
you.
I'm sure it would be very clear, inshallah. Right. Okay. We want to see the principles of integration and what is their impact on their impact on the developing an integrated module. Now, integration focuses on key issues, as it is promotes learning in context, clinical scenarios. Again, this is very, very important. Excuse me. अभी मैं ठहर के कॉल करता हूँ. Sorry for that. Okay, now the first principle of focusing on the key issues. This is an important attribute of integration, that it promotes learning in context, in real life situations, in clinical scenarios. So teaching is in real life context, and themes are used for that, and we will explain further in a short while what the themes are. Second, it adopts holistic approach, covering all aspects of a topic in holistically integrated fashion. So once we start talking about a topic, we don't cover that topic in pieces. We will cover that topic from all related aspects. Thirdly, it focuses on core curriculum. the must-know knowledge. Ensuring teaching of core curriculum, essential knowledge, skills, and attitude. But that is what is the least required. That does not mean that we cannot go more than the core curriculum, but core curriculum must be covered. That is the minimum requirement. So you can see that how this principle would affect our effect on our exercise of developing an integrated curriculum, that it emphasizes on themes. It emphasizes that the subject or topic should be covered holistically in integrated fashion, and the minimum requirement of that topic would be the core knowledge. So that is first principle. Second principle enhances construction of knowledge, and it does it through integration of basic and clinical sciences. Here I give an example, that integrated teaching of basic and clinical sciences. For example, we are taking a session and we have taught the functions of thyroxine. Once we have taught functions of thyroxine, then we just take a 5-minute break and ask students to think about it. What would happen if there is lack of thyroxine? What would happen to the body? Or what would happen if there is excess of thyroxine in the body? So once we have covered the functions, and then we integrate it with clinical, but we stimulate the students to think about it, that based on the functions of thyroxine, how its lack or its absence or its excess would affect the body functions, and that would stimulate the vertical integration. Second, deep understanding of new concepts. It promotes critical thinking and application of knowledge. We are aiming at Bloom's taxonomy of C3 to C5 level. Third point, it identifies gaps in the knowledge. So, and then once students have identified the gaps in the knowledge, they are encouraged to search for the answers and then use of resources. And this is a special feature of, for example, in problem-based learning, inculcating the skills to identify the personal weaknesses and how to address them through lifelong learning. So this is how the integration helps in enhancing the construction of knowledge, and this is how it impacts our construction of integrated module, that we have to make sure that there is vertical integration in our teaching exercises. There is a critical thinking. We have to go for application of knowledge rather than simply comprehension. And we have to promote the critical thinking and the ability of students to recognize their own weaknesses. Application of newly acquired knowledge to solve problems, and this is what we do in case-based learning sessions. The third principle is it promotes application of knowledge to real-life situations by learning through problems, using teaching approaches that use real-life case scenarios like PBL or CBL. So even in the so-called preclinical years, our teaching is directed by the real-life problems. Using the knowledge gained to solve new problem, which we use in case-based learning. And after here is another example similar to that of thyroxine. Let's say we have learned the functions of insulin, and then we can ask students to think about what would be the effect of lack of insulin are lack of function of insulin and what derangements in body systems, let's say in fat metabolism and protein metabolism or carbohydrate metabolism, will take place in the body. So moving from, for example, physiology to the medicine and application of physiological knowledge into the medical practice. Getting feedback and improving the teaching. The fourth principle, foster clinical thinking and lifelong learning skills, and this is done through PBL when students generate hypothesis, interpretation of data like in case-based learning, searching evidence, making decisions like in case-based learning, finding relationships, identifying differences, and we must make sure that our teaching methods and approaches cover all these above effects. And the fifth principle that enforces staff development. So improving teaching skills, mastering new techniques, learning new methods and techniques of teaching, learning how to give constructive feedback, enhancing evidence-based teaching, that is questioning the effectiveness of existing teaching methods and using evidence-based teaching methods, keeping high standards both in teaching and assessment, and achieving excellence in areas of expertise. So this is how the 5 principles of integration influence or have impact on our approach in developing an integrated module. Okay, now so far any questions apart from Dr. Adnan question about theme, which we will discuss shortly. Any other question?
No, sir.
Right.
We can proceed.
Okay, we can proceed. Thank you. Now, next is looking at the levels of integration and their impact on developing an integrated module. So this is the statement by Professor Harden, although quite old, 1984. In the SPICES model of educational strategies, integration is presented as a continuum, with full integration at one end and discipline-based teaching at the other end, with intermediate steps in between. What it means is that it is not all or none situation. It's not that either we have integrated curriculum and or we don't have integrated curriculum. There are 11 levels of integration between discipline-based and full integration, and our curriculum would be on one of these 11 levels. I will explain some of these integration levels, especially their influence on developing an integrated curriculum. These are those 11 levels: isolation, awareness, harmonization, nesting, temporal coordination, sharing, correlation, complementary, multidisciplinary, interdisciplinary, and transdisciplinary. The first 4 steps on this ladder, they emphasize on the subject or discipline. The subsequent 6 steps emphasize integration across several subjects or disciplines. And the final step is the full integration, where the student takes more responsibility for the integration and is given tools to do so. Let's look at the first level, because this would help us in real understanding what integration is all about. The isolation, fragmentation, or anarchy. This means that students attend a lecture in anatomy and then move on to a lecture in physiology, with neither lecturer being aware of what was covered in the other lecture. So totally independent. Or department or subject specialists organize their teaching without consideration of other subjects or disciplines. For example, anatomy may be teaching musculoskeletal system, physiology teaching cardiovascular system, and biochemistry may be teaching renal system. So there is no link. At least I was trained in this system. I don't know about you, but when I was medical student, that was the situation in our medical school. In this level, each discipline looks at the curriculum content in terms of areas to be covered, depth of coverage, sequence and timing from the perspective of their own discipline. So each discipline is independent in doing all the decisions themselves without consulting others. No attention is paid to other related subjects or disciplines which also contribute to the curriculum at the same time. The relationship between subjects is not explicitly covered, and the related topics from two disciplines are not intentionally correlated. Each subject is seen as an entity itself, and the objectives are seen as mastery of the subject. Too much emphasis on the subject. That's why the anatomy lecturers want to make the students anatomists, and physiology lecturers want to make students physiologists. So there is mastery of the subject. Too much emphasis on the subjects and disciplines, where the integration would be much different than that. There would not be emphasis on the subjects. Now let us jump to level 5. And this is the temporal coordination, parallel teaching, concurrent teaching. And now see, the difference is that each subject remains responsible for its own teaching program. However, the timing of teaching of topics within a discipline is done in consultation with other disciplines. Now, when they are preparing the timetable, they would consult each other to see the same or similar topics are covered at the same time. The timetable is adjusted so that topics within the subject or discipline which are related are scheduled at the same time. Similar topics are taught on the same day or a week. It is still completely subject-based. However, the timetable is such that each discipline is teaching the same system or same area. For example, physiologists teach the functions of the heart at the same time as the anatomist teaching the structure of the heart. So you saw in level 1, there was no coordination at all, but now at least there is coordination, and students are learning about the same discipline under different different disciplines. Students study the concepts of different subjects separately and are left themselves to uncover the relationship. Although the timetable is coordinated, but still each discipline is covering their own bit. So they are not touching what is being done in the other disciplines. Next is the level 6, which is moving to the joint teaching sessions. Here, the two disciplines may agree to plan and jointly implement a teaching program, although still subject-based, but some joint session. And the why or what makes the basis of this joint session is the overlapping concepts. Our ideas make the basis for shared planning and teaching And now here students are shown the relationship between the two disciplines. We saw in level 5, students were left to make this relationship or understand the relationship between different disciplines at their own. But here in level 6, by having these joint sessions, so students are given the opportunity to see the link between the relationship between the two disciplines, and teachers guide them. The examples are, let's say, a joint teaching session between pediatrics and obstetrics. This is a case of diabetes mellitus during pregnancy and infant of diabetic mother. So there is a session where obstetric people are covering the diabetes mellitus during pregnancy, and at the same time the pediatricians are talking about the infant of diabetic mother, so what complications can occur, or obstructed labor and birth asphyxia. So there is a common or a joint session between pediatrics and obstetrics and gynecology. Other example, community child health teaching program is run jointly by the Department of Child Health and the Department of General Practice. So these two departments, they work together, and in this way they have some joint sessions which help students to understand the relationship between these two different disciplines. Another example is parasitology and pharmacology run a joint session on malarial parasite and anti-malarial drugs. Let's say the parasitology is talking about the life cycle, and then the pharmacology pointing out that at what level of the malarial parasite life cycle would certain drugs have their effect. So in this way, these joint sessions would show the relationships between the two disciplines, in this case, parasitology and pharmacology, and this is level 6 of integration. Level 7 of integration, which is the correlation concomitant program or democratic program. And in this, what happens is that the emphasis still remains on the discipline or subjects. However, within this framework, integrated teaching sessions or a course is introduced in addition to the subject-based teaching. The best example is hybrid curriculum, where we have traditional lectures as well as problem-based learning sessions. So that is going to level 7. And multidisciplinary seminars or symposia is another example. Here, what is that the different disciplines come together. Like I was giving the example of malarial parasite and pharmacology. If we can expand it, so there would be, let's say, medicine teaching about the malaria, the pediatrics teaching about malaria, maybe obstetric gynecology teaching about the effects of malaria on pregnancy, and similarly at the same time pharmacology and parasitology would be there. So 4 or 5 disciplines coming together, conducting one session where all the aspects of malaria are covered. So this is the multidisciplinary seminar or symposium, and that is, although it is still subject-based, but that is what is the level 7 of integration. Yes, Dr. Khalid, please.
Sir, when we talk of joint sessions, is there any minimum number of disciplines that can join in a joint session? If, say, for example, in first year, we have to have anatomy, physiology, biochemistry, medicine, and surgery. All 5 contributing would be a joint session, or even 2 or 3 can contribute to a joint session?
Minimum 2, and maximum should not be many as well, because otherwise it would be diluted. So maximum may be 4 or 5, but minimum 2. Basically, the definition of common seminar or common a common lecture or multidisciplinary seminar is that a topic should have link with at least 2 disciplines. So the minimum, like here we say the parasitology and pharmacology, but then we can bring in clinical as well. So that would increase, would have this vertical integration between basic sciences and clinical sciences. And it's not necessary to have it so frequently. Let's say in our some of the institution, it may be once in a month or twice in a month to organize such activities that different disciplines come together. It may be lecturer based, where the lecturers actually give their presentations, or it can be student based. So basically is that each discipline can train or guide 1 or 2 students, and they come, and then this program is held. Usually it's 2 to 2.5 hour session, and everybody comes there, and when students are presenting, the lecturers would give their feedback. So that's how it is conducted.
Thank you, sir.
Right.
Any example of student based? Sorry to disturb.
Sorry?
Any example of student based?
Any
example of student based activity of integrated session?
like even for example, the one I just said, the parasitology and pharmacology, it may be the students are presenting, but lecturers are there to give feedback, and usually these students are guided by the lecturers beforehand. So it is the students are presenting, but lecturers have already guided them, and they are there to help them out. So it depends.
It will be a seminar kind of presentation.
Yes,
it will be a
yes.
Seminar kind of presentation.
That's right. That's right.
So student can be assessed regarding the micro teaching skills or such kind.
Yes.
We can use the PG teachers, PG students for that purpose.
Sorry.
I think it is more beneficial if we use the PG students for such kind of purpose.
It depends what are your objectives. The example I give, for example, malarial parasite, that is done by the undergraduate medical students. They would go through the life cycle, and at every level where, let's say, where the quinine works and where the other anti-malarial drugs are chloroquine or quinine, so their mode of action and the level of action would be highlighted there and then. And I can see it can be a very stimulating and interesting session, that during the life cycle, okay, it's the hypnozoite and how to cover or treat hypnozoite, and then the pharmacology people say, yes, we give quinine to what's the different name of drug? I'm forgetting. It's which is hypnozoite to kill the hypnozoite. So in that way, the students can see the relationship between the life cycle and the pharmacological agents, and how do they work.
Okay, thank you.
Yeah. Okay. Another way may be to give an assignment which involves multiple disciplines. For example, here is to prepare an immunization schedule. So then they have to learn about the immunization, as well as the different levels of immunity and how does it work, and at what age what vaccine should be given, why some vaccines cannot be given earlier, and why some vaccines are given only later. So in that way, again, they would be learning a lot to complete that assignment. Yes, Dr. Ahmad, please.
Thank you, sir. I'd like to mention one other thing. We benefited from these joint sessions. We're doing them, and we were having problem with the departments. Sometimes their teaching the same thing, but they're mentioning different approaches, different things, slightly different things.
Right.
For example, parasitology is teaching about the treatment, but when they come to pharmacology, we teach slightly different things.
Yes.
There were really some conflicting issues about the topics, and
Right. That's
this was so confusing for the students, because it's really important to give one approach, one way guidance.
right.
That's why it helped us to resolve the conflicts between the departments. In the same panel, we were talking about the issues, and in front of the students, actually, we were, mentioning the literature, and we were settling down what should be the, the optimum approach, and so on and so forth. So these joint sessions not only, they expand the students' understanding of the topic, but also gives them one approach, one alignment in the topic, and clears the context of the topic. So it is really important. Yet it is not easy to operate with exceeded number of the students.
Right. Absolutely right. Thank you very much. Actually, that's totally a new thing you have shared with us. That yeah, that's another important aspect, that students get a similar or same approach everywhere. The other point which we should keep in mind about this common session is that these common sessions usually cover the breadth of the topic. That does not mean that the later on it should not be taught by the specific disciplines, because let's say we have this session on malarial parasite, but then let's say they come to the pediatrics, then we would have bedside teaching or other sessions on malaria as well. So basically, as I said, these common sessions, they cover the breadth of the topic, and usually the depth is covered by the concerned disciplines. And this is one, I think, quite good way of integration, vertical integration between basic sciences and clinical sciences. So moving on, again, the same thing happens in problem-based learning sessions. Based on the triggers, both basic sciences and clinical aspects can be covered, again, promoting vertical integration. The next level, which is the complementary program or mixed program, and here it is integrated sessions represent a major feature of the curriculum. So most of the curriculum is now being taught through integrated sessions. And the focus of teaching is a theme or a topic to which different disciplines contribute, right? So we have a theme, and then different disciplines are contributing to that, and we will go into the detail, and also we would answer the question raised by Dr. Adnan Khalid. Okay, now let's see, how do we develop the theme? Because this level 8 is based on, the curriculum is based on the themes. So let's talk about a module on hemopoietic, hematology, and lymphoid module. Then first we identify the major contributors of teaching basic science teachers in disciplines in that module. Now, in this hemopoietic module, the major contributing disciplines would be physiology, biochemistry, pathology, and pharmacology. And we request those disciplines to give, let's say, what are the first 3 topics. Just an example, first 3 topics you would like to teach in this module. And let's say, and then they come up with the topics. At the moment, I'll just give one example of this. Let's say physiology says that we would teach hemopoiesis. Biochemistry says that we want to teach the structure of hemoglobin. Pathology says anemia. Pharmacology says iron therapy. Now just think which theme or which topic can connect all these four areas: hemopoiesis, structure of hemoglobin, anemia, or iron therapy. What comes
Iron
to
deficiency anemia.
right? Basically is anemia. So the theme would be the anemia, right? Because this is how we arrive at, we look at those topics and then we find out which clinical condition can actually combine or connect all those topics. And then based on this, let's say we came up with the theme of anemia. Now, under anemia, we have to cover hemopoiesis, hemolysis, and hemorrhage. So based on that, we will prepare a timetable. I'll come to that a bit later. Here is another example. This is about the cardiovascular module. And this is actually I did this exercise in my own medical school, and I got these topics from different disciplines. The physiology says that they want to teach properties of cardiac muscle, conduction system of the heart, the cardiac cycle. Anatomy says we want to teach gross anatomy of the heart, blood supply of the heart, development of the heart. Biochemistry, cardiac biomarkers, hyperlipidemia and its impact, biochemical changes in myocardial tissue, pathology, myocardial infarction, heart failure, infective endocarditis. Pharmacology, antiarrhythmic drugs, drugs used in heart failure, drugs used for angina and myocardial infarction. So we obviously once we have the module, let's say CVS module, it would be for 7 or 8 weeks or what number of weeks. So we have to find these themes for each week. Sometimes it may be more than a week as well. So let's say based on this, what would be the theme in the first week?
MI,
Chest
myocardial
pain.
infarction.
Right, absolutely right. Yes, MI would unite many of these topics. And then we obviously later on we can have, let's say, infective endocarditis, let's say the theme of the second week, or heart failure later on. Basically, if you see, most of the time it would be the pathology that their input would make the theme because they are related to the clinical. Yes, Dr. Adnan. Yes, please.
So the theme can be either a clinical situation like chest pain, or it can be a disease like myocardial infarction. So which is better? If you have to choose a theme for this very example, should it be, say, chest pain or myocardial infarction?
When we are, because chest pain would be then so many other causes as well, not only CVS. There would be many other causes, but here we want to relate to CVS only. And then it's for, especially for basic sciences, it's important to have a clear theme. And based on that, once we have put these topics in the timetable, we would see what additional, for example, we would like to invite a physician to give some input on myocardial infarction. Yes, Dr. Khalid.
So then what would be the difference between a theme, a topic, a disease?
No,
What is the difference?
I think they can be used interchangeably. But the theme seems a better term because it combines many things. Topic can be only one, whereas theme means that it is many different things are going towards that. I'll show you a little bit later as well that how it helps to have a theme. And then let's say here the theme is myocardial infarction. So physiology is contributing to it, anatomy is contributing to it, pharmacology is contributing to it, pathology is contributing to it, then internal medicine is contributing, maybe family medicine is contributing to it. So every discipline is contributing to that discipline, that theme. In this way, we are emphasizing on the theme. We are not emphasizing on the disciplines. And that's where it says that the integration breaks down the boundaries between disciplines, because our emphasis is not on anatomy or physiology. Our emphasis is on myocardial infarction. So that's how we identify. This is probably the best way to identify the themes for that particular module. Here is the timetable. The one I mentioned, the anemia. So theme is anemia. And then we have this, this is week 1, the details of that. Now here we have first week, here is introduction to the module. Then this is the normal hemoglobin and overview. Then is hemopoiesis, blood grouping. Then is hemolytic anemia. Then is the abnormal hemoglobin and hemoglobinopathies. So you see that the different disciplines are contributing to the theme of the week. Then there is a clinical, where is a general history taking and general physical examination in a patient with anemia. The PBL sessions would be also directed towards that. However, for example, our PBL session is on hemolytic anemia, then we would not be teaching those topics in our lectures, because that would be covered in the PBL, and we do not want the students to just concentrate on the lectures, but they should be searching for that information at their own. So in this way, once we have identified the theme, then whatever content we have identified, we will plan it in a sequential manner in the timetable. Now that was the level 8, where it's covered under themes. Next is level 9, which is multidisciplinary. Yes, Dr. Khalid, please.
So sorry to interrupt you again and again.
No. It's that's what I really want.
I presume that the timetable that you showed was for first year.
Yes, yeah, that's right. Because the integration is we start from. Generally, what happens is in our medical schools, first we have a foundation module where we teach all the basic things, basic terminology, etc. The general, for example, general anatomy, general pharmacology and physiology. So because students come from different backgrounds, so in that foundation module, we bring them on the same level, same understanding, and we cover the general subjects there. And when they come to the modules, they are looking at more special or specific areas. So
for example, then is in this timetable that you showed that they would be taught history taking points in this situation.
Right.
So we are talking of first year. So are we exposing them to clinics? Because in
right.
our setup,
That's right.
In our setup, we're still going for clinics in the third year. And although we
yes, yes, that's right. I'll mention a bit later. that what we call is early clinical exposure,
Exposure.
right?
So
That may be in the hospital or maybe in the clinical skill lab where we have a simulated patient or a real person there where students communicate with that. That is component of early clinical exposure.
and so then can we also take this theme vertically or longitudinally across as part of vertical integration, so that we are teaching this in the same, we have a recurring theme in different levels of years.
Absolutely, sir. Absolutely, sir. Actually, I think you are reading my mind ahead of me.
Sorry.
Yeah. Many things which I want to mention a bit later, you bring it earlier. Absolutely right.
My apologies, sir.
No, that's good. That's good. We are on the same wavelength, right? So
Thank you.
I'll bring that point, but you are absolutely right there. Okay.
Thank you.
Now
Thank you.
the level 9 we were mentioning is that a multidisciplinary approach brings together a number of subject areas in a single course, with themes, problems, topics, or issues as the focus for students' learning. The courses are developed around body systems such as CVS, GIT, or CNS, and so on, and all the disciplines contribute accordingly, and this is what we call is integrated modular program. All right, like we saw just now, that hemopoietic module, and then is the anemia and all the other subjects or disciplines contributing to that. So this is what is integrated modular program, means that our teaching is organized under body systems. Each body system has a number of weeks of timetable, and each week or more than a week or less than a week period has a theme, and where all the disciplines are contributing towards that the theme. This is what is integrated modular program. Now, like here we say the CBS module for 7 weeks with 7 themes. Yes, sir, Dr. Rohan.
Sir, I want to ask that you have said that all these courses are developed around some body system like CVS, GIT.
Right.
So it starts from first year onwards.
Yes, first year, because as I mentioned earlier, before starting this, we would have a foundation module.
Around for how much duration?
It can be up to 4 months, 6 months.
4 to 6 month foundation module, where all the subjects are teaching their general part.
Let's say general embryology would be covered there.
All the subject discipline, like you have mentioned, that like general pharmacology is also taught during the
yes,
foundation.
that's right. That's
general
right.
pathology also.
Yes, that's right. So
all the subject disciplines are teaching the general part in 4 to 6 months.
Yes.
And then such body system part is started.
That's right.
Okay. Because here the systems are quite bit different. Here in our system, we start only anatomy, physiology, and biochemistry in the first MBBS,
right.
first year.
Right.
Then other subjects takes part in second year, like pathology, pharmacology, microbiology, and forensic.
Yeah, many medical schools, many medical schools are doing that. Yes.
Clinical posting starts from second year onwards, not in the first year.
Right. Yeah, I mean, there could be little variation here and there, as long as the principles are there and it's being followed up. Like I said, the foundation module, you may think that 4 months is not enough, you want 6 months or you want 8 months, but that's okay. Based on the institutional requirement, that a little bit variation here and there would be fine.
Okay.
Right now.
Okay.
So one approach is that we divide this program under the body systems. And now this is what I think the Dr. Khalid was mentioning to some extent. Now I want you to think can we, let's say we have these body system modules in preclinical years. Can we bring the same concept in the clinical years? Let's say rather than having a medicine module or pediatric posting or surgical posting, we have a cardiovascular posting where pediatric is doing their contribution, medicine is doing their contribution, surgery is doing their contribution. Does it seem odd to you, or you think that's...
It seems only natural. The only thing is that we are not looking at it the way we want.
It makes sense on the
Because
paper, yet it is so hard to organize
implement.
those things because the clinics are so busy with the patient duties.
Right.
So they want to organize their own time with the students in the time of their course. So it makes a lot of sense, and it is perfect on the paper, but I don't think it is applicable in the field.
Basically,
So once we say that it is,
this statement is to provoke you.
yes, sir. So once we say that it's not applicable, we're really killing it. The thing is that how can we, there is a concept of curriculum time. So we
Right.
have only 5 years to us or whatever MBBS program that we are running. So within that time, like we were talking earlier about the foundation module. So everybody is teaching their general subject anyway, general component.
Right.
So it is the rearrangement of the same curriculum time. There's no additional curriculum time required for this.
Absolutely.
And
Right.
similarly, the problem with integration is not the problem. The way we integrate is that the faculty buy-in and the faculty integration is very difficult. That is the main thing. Students are already integrated. We were integrating whenever we taught in isolation.
Right.
But we integrated. We intend to integrate. Now we are trying to integrate for the students, but for that to happen, we have to integrate ourselves first. We have to break down our own boundaries, our own silos. And the thing is that we are so much worried about content coverage that we forget that we are doing many redundant things. So if we take out
That's right.
redundancy and coordinate, then we can actually cover the content within the same curriculum time without redundancy. We don't have to say because once we talk of the
Sir,
disciplines, then I
it's
have to
not
cover this
only
content.
redundant. It's not only redundancy. It's lot of repetition as well.
Absolutely, sir.
Yeah.
Can I add something on this topic?
Yes.
I believe
Please.
6 years is too much for this kind of education, but that's what we do. Let's say internal medicine. Internal medicine is teaching their students not as a general practitioner. They are teaching them like they are going to be internal medicine resident or specialist, because when you get into something deeply, it gets more and more important to you. So they're trying to especially clinicians, no offense, but they're trying to teach everything they know, and they think the things about their discipline is the most important thing in the world. But I usually question if those undergraduate students need that kind of detail. For example, in the eye diseases in my university, they teach, they use the same slides for their residents, for the fifth graders. So if we can make all the professors understand we are trying to raise general practitioners, and if we can decide what we should teach and what we shouldn't teach, we would have plenty of time. Then we can use that time for problem-based lectures and interactive courses and so on and so forth. We should change the way we think we teach the students.
Actually, just
may I add on to that, sir?
just 2 points here. You said very rightly, it is important to know what to teach. It is also important to know what not to teach. Number one. Second, we are aiming at producing a safe house officer. And that house officer continues to learn during house job. In Malaysia, it is 2 years, in some countries, 1 year. So if we keep in mind that our aim is to produce a safe house officer, not a consultant, I think that would help. That would help in this area. Right? As I said, this was, yes, Dr. Khalid, please. Yeah.
Just to add on to what Dr. Ahmed said, what you said, basically, I think it is not about us. It is not about teachers, it is not about how we can teach or how much we can teach and what is our prowess of teaching.
Right.
It is what are the students learning. So the first word should be not teaching and learning, should learning and teaching.
Right.
So the emphasis has to be on learning, not on teaching.
Right. Mm. Actually, I was reading a definition of teaching, and beautiful definition. The teaching is a process to facilitate learning.
Absolutely.
We have, as a teacher, medical teacher, we have to facilitate the students to learn. That is our main job. Anyway, as I said, I put up this slide to provoke you to think about different areas. But later on, we will see that in Dundee, how they are doing it in a slightly different manner. Okay, now, apart from dividing the curriculum according to the body systems, there is an alternate way. We can divide it according to the stages of life cycle. For example, conception, birth, childhood, adolescence, adulthood, elderly, to death. So that can be an alternate method of organizing the curriculum. And the theme may be a combination of information and skills which are relevant to medicine, such as tasks, ethics, or health promotion. Like this is what Dr. Khalid was asking, that whether they can be interchangeably used. Okay, coming to level 10, which is discipline combined in one course. Here is that in interdisciplinary integration, there is a further shift of emphasis to the themes as a focus for the learning. So themes are becoming more and more important here. Interdisciplinary teaching implies a higher level of integration with the content of all or most disciplines combined into a new course with a new menu. I give you an example of concept of this One Health, and it has become more prominent after this COVID, that human health is not just related to human, it is related to animal health, it's related to plant health, it's related to environmental health. So there could be a course, let's say One Health, where the students are taught about the links between human health, animal health, plant health, and environment. And all these subjects would bring in their own learning outcomes and combine together and form a new curriculum, So that is coming towards the level 10, where the most disciplines are combined into a new course. The other examples are here is the common learning outcomes from different disciplines are brought together to decide. So what would happen is that there is no reference to individual disciplines. They are not identified in the timetable. It's only the topics are given. No discipline is given. And it is here at this level, there is loss of disciplines perspective. We are not talking about disciplines. We are just talking about the theme. And so let's say, they would not be saying this anatomy or physiology. It would be saying let's say the sessions on blood supply of the heart, functions of the heart. So it goes towards the topics rather than the disciplines. And these, so common learning outcomes from different disciplines are identified and integrated. A teaching, learning, and assessment method is planned and implemented. This is actually the best example is interprofessional education, where different disciplines, they come together. Each discipline has its own learning outcomes. They combine together and come up with a common or a new session. I'll give you an example later on. The other example here is a pediatric and community medicine or maternal and child health. These are examples of level 10, where two different disciplines have come together and formed a new course. The final level, which is the level 11, are transdisciplinary. The curriculum transcends the individual disciplines. Now, here are a couple of examples. The curriculum in the first 3 years of the student's studies is vertically integrated around the body systems. In the last 2 years, students are attached to periods of time to a range of specialties in the hospital and community and experience the various contexts, problems, symptoms in which medicine is practiced. It would be clear in the next slide. But here, just two things, that the first 3 years, the curriculum is vertically integrated, and last 2 years is divided into problems, symptoms, or themes. This is what is happening in Dundee, for example. A total of 113 clinical problems or tasks or themes provide the students with a framework for integrating the experience. So once they have covered the first 3 years, which is a vertically integrated curriculum, now for last 2 years, they have these 113 problems or themes, and they have to work on that. And how does it work? For example, there is abdominal pain is one theme. Now, this is what we were talking about, whether we have to have specific or we have to have a general, like chest pain or myocardial infarction. But here in this case, it is general, abdominal pain. Now, what happens is that there are 113 such topics, and students work on that, and they work during different postings. For example, this abdominal pain is a theme, and students have to learn about that. So they would learn it during surgical posting. They would learn the surgical aspects. Then they move on to medicine. They will learn again abdominal pain from the medical point of view. They move on to pediatrics. Again, they would learn about abdominal pain, what happens in pediatrics. And then maybe in ONG, they learn about it. So it is one theme, but as they are moving through different disciplines, they are learning about it, and in this way, they are integrating. This is the more or less the concept which I was talking about, that if we have the modules based on the body system in the clinical years, can that work? So this is a slightly different way to approach that. For those 2 years, they have their curriculum. No, important thing is how they have come up with this 113 problems or themes. And in this way, they cover all the clinical conditions. And students are able to integrate between medicine, surgery, pediatrics, ONG, and others. And this is being practiced in Dundee. Yes, Dr. Rohan, yes, please.
Sir, here in India, we usually tell it like a task-based integration session.
Right.
We usually call it as task-based, like abdominal pain you mentioned, like chest pain, abdominal pain, CPR, such
Right.
kind of issue. And we are conducting the integrated session according to these tasks.
Right. Yeah.
Can you tell me that is where the number is coming 113? Is it 113 problems identified in your curriculum?
It's in Dundee,
It's
Scotland.
in the Scotland.
Yeah.
113 problems are identified
Yeah.
there.
And what you are saying is task-based is very good. Actually, that's the highest level of problem-based learning.
Yes. We usually conduct the integrated session according to the task-based.
Yeah.
We identified such kind of tasks, and we usually teach all the disciplines are coming and
Right.
teaching
That's
centered around that task.
that's excellent. That's excellent. Because
Can you give me a little bit more information around of these 113 tasks? Any reference for that?
for example, rather than abdominal pain, let's say you can think of, let's say, chest pain.
Okay.
And then let's say in medicine, you would think of cardiac causes or respiratory causes. In surgery, you might think of different causes. In pediatrics, you would think more of from pediatric point of view. So basically, is that the same problem or same task as you are saying, but looking from different disciplines or different specialties. So in this, and to do that, they have this study guide or electronic study guide, and that helps students to coordinate this. So in other words, what they have done, that rather than having, they do have postings, but that postings would be based on these tasks, as you said, not on the usual lectures type.
Can you provide me such any reference material for this to study?
Yeah, okay. Please remind me during later on in the WhatsApp group, and I'll send you the article.
As well as just now, Aisha ma'am have said that at Aga Khan University we had 120 clinical presentations that guided the curriculum. Ma'am, can you send me the reference material for that thing?
Yeah, it would be similar approach. Yes.
It is a request from Aisha ma'am that please send this 120 clinical presentation.
Yeah.
Thank you. You can send me on WhatsApp. You can send on the group.
That's in Aga Khan, Karachi.
Yes.
Yeah. So let's say the Dundee has these 113 and Aga Khan has 120. But
kindly share the reference material for this on the WhatsApp group.
Yeah, inshallah. Maybe Aisha can give about the Aga Khan as well.
Thank you.
Okay. Now so this is another example in South Dakota, the ambulatory care setting. The students spend their whole year 3 attached to clinics staffed by physicians from various specialties. And the students are not on a given specialty for a block of time. Rather, the required specialties are simultaneous or integrated, especially the multidisciplinary clinics or family medicine clinics, where the patients, all different types of patients are coming to the same clinic, or you can say the GP kind of clinics. So then they say the issues from different perspective in those clinics and coming from different backgrounds. So so this is how the levels of integration, and we see that how that level of integration actually impacts our approach to develop an integrated curriculum. In summary, the level 1 is fragmentation, where there is no connection in teaching session. Level 5 is coordination in the timetable. They're teaching similar topics around the same time. Level 6 is a joint session. I gave the example of diabetes and infant of diabetic mother. Level 7 is hybrid curriculum, where is a traditional lecture plus problem-based learning session. Level 8 is organizing the timetable under theme. Level 9 is integrated modules following body systems like CBS. Level 10 is a combination of discipline to develop new courses like One Health or Family Medicine. And level 11 is vertical integration in first 3 years and problem or task in the last 2 years. So that is the summary of different levels of integration which we have discussed so far. Okay, now here is a question. What is the level of integration in your curriculum? Okay, maybe we start with Dr. Rohan. What do you think based on this, our description, where would
Sir,
you
what-
put the
what
your
we are-
curriculum on it?
Sir, we are following like that. In the horizontal curriculum is already practiced in all the clinical years, all the years. Here,
Right,
that all the, like in first year anatomy, physiology, and biochemistry, we sit together and we have made the our teaching part horizontally aligned.
right,
That we use the term alignment here. Alignment here, that we are aligned our topic, that the time we are teaching the thorax part, like in the heart part, the
Okay.
same time physiology teaching their part.
right.
So we have aligned the curriculum as well as it is also aligned in the final year also.
So
So
that
the
is
horizontal integration
that
is
is
completely there.
coordination.
We
the-
use the term alignment here. So
Yeah,
that is alignment of the curriculum is there. How that is horizontal integration.
yeah.
Regarding the vertical integration, what we are practicing is that we usually conduct it task based.
Right,
We usually and task based, sometimes in the topic based also, like
Right.
for the second year faculty, that
Right.
is pathology, pharmacology, microbiology, and forensic. They conduct some disease specific like tuberculosis.
Right.
So they are conducting a vertical session of tuberculosis in the second year. Little
right,
bit part will be taken by first year faculty. Little bit part will be taken up by the final year faculty. But
Right.
mostly it will be focused on the second year faculty.
right,
Again, the tuberculosis will be repeated, integrated session will be repeated in the final year.
right,
But the major part will be taken up by the final year faculty.
right.
And little bit part will be taken up by the first year and second year faculty.
Maybe after this session, you can look at it and try to see that which is the nearest level of integration which your institution is following. May I ask Prof. Hamza? Prof. Hamza has joined us from Saudi Arabia, and maybe your experience, Prof. Hamza, what level of integration you have?
Yes, sir. Good morning, everyone. I'm very sorry because simultaneously I'm having some other administrative work. That's why I'm not. But I can hear that all excellent from Professor Ahmad and Professor Adnan and you and all of you
Right.
are talking about. Yes, we our university or the College of Medicine and University, we were the first to get the accreditation from our national accreditation qualification center. That's the NCAA for that. And that I was 2008 up to 2008. It was traditional curriculum, and they said you have to change, otherwise you cannot get the accreditation.
Right.
So we started the system-based integrated curriculum. So we developed for the first year foundation block,
Right.
cardiovascular block, respiratory block, renal block. So these were the 4 or 5 basic courses. So in very brief, our curriculum, we say we are integrated, but where we are, it is still in the first ladder or first stage or second stage, because we are, what we are doing, there are physiology, their lectures, anatomy, the lectures, but where the integration it comes in our teaching, that's on the PBL. So problem-based learning, student, they learn the physiology, pathology, anatomy at the level of heart disease or the MI or anemia or whatever it is.
Right.
And also our assessment and that is the short answer questions. A patient presented with the weakness, what will be the differential diagnosis and how you can make and these things. So again, it is integrated and so on. So very brief that we started in the 2008 for first year and the second year. So we have 9 blocks. All these is the system-based curriculum, which is integrated. We can say level 2, 3 is still there and segregated and so on. But we are doing our best, especially at the level of teaching and the assessment. Thank you very much.
I think, Prof. Hamza, that seems like hybrid curriculum.
Exactly. We can say that is our curriculum is a hybrid.
Curriculum.
Yeah. And let me share one important point that our curriculum in the first and second year is really we are trying best to integrate. But after that, the third, fourth, and fifth year, this is all the discipline-based, meaning the clinical science. So in the clinical science, usually we introduce the basic science in that, but it's not that. And everyone teaching that. And as Professor Ahmed and others, they were talking about that medicine people, they want to teach everything in medicine. In the surgery people, they want to teach everything in the, so those are things are going on everywhere, all over the world. I have visited a lot of colleges and here and there at the region as well as the international level. And these are things going on. So integration, pure integration is really, as we were talking about, it is in the paper.
Right.
but people are doing a lot.
I think, Prof. Hamza, for you, the next step could be common sessions.
Yeah, that's Prof. This is 14 years I'm trying for, but I could not succeed.
I think you have hybrid curriculum, but if you can introduce, let's say, to begin with these common lectures, so there would be some vertical integration.
Let me tell you, Prof, one of the important point that our college is the oldest college in the region.
I see. Right.
Yes, the King Saud is the oldest college in the region, in the whole country.
Right.
I was involved in development of the curriculum of Al-Majma. This was a new. And there I could introduce the things, and they are so integrated from the beginning. But our people who are very old and then they're traditional, so they don't want to change.
Right. Yeah, it's easier for new medical schools rather than the established schools because the change is not easy. Let's see, Dr. Aisha Khalid. Can you share what's the level of integration in your institution? Dr. Aisha Khalid, please. Maybe she can't hear me. Right. Anyway, so we have, I think, a clear understanding of the principles of integration and level of integration and how it influences our approach in preparing the curriculum. So I think time is catching up. Okay. Now, some important key points of an integrated module. And the first thing is, remember we started with the learning outcomes, right? Let me tell you, it's not easy because what would happen is that the different disciplines have to bring their own learning outcomes, and then you have to combine them and come up with the common learning outcomes. So this would be actually exercise. It would be difficult to begin with, but once you have done for one module, then the subsequent modules would be relatively easy. So the different disciplines have to come and contribute in that, and the let's say then medical education unit should have that meeting and come up with a common learning outcomes with the consensus of all the disciplines involved. Here I have mentioned the knowledge domain, and I have mentioned the skill domain and effective domain, and I have sent these slides to you so you can look at it at your free time and see that how these things have been integrated in this. So the other key point we were mentioning about the early and continuous clinical exposure is an important key component of integrated curriculum from the, let's say, after your foundation module, when you start with the body system modules, the early clinical exposure should be included. Usually it is included in the last week of the module when students have gone through the theoretical aspects, then they go and see the clinical. If possible in the hospital, otherwise it can be done in the clinical skill labs. And this helps them, the students, to apply theoretical knowledge in real world settings progressively. Second is interprofessional education. I mentioned earlier is best example of integrating different disciplines. Integrated modules often involve learning alongside students from various other health care disciplines. I'll give you an example later on. And this fosters collaboration and understanding among different healthcare professionals, which is crucial for effective patient care. Competency-based education, again, and the key component of integrated module, the focus is on achieving specific competencies or skills rather than just completing a set number of hours. I read a lot about what is happening in India because I'm in some of the WhatsApp groups, and I see a lot of complaints from the people about the National Medical Council introducing competency-based education, and many people are very unhappy about it. I think they are still on the learning curve. The simulation-based learning, simulation exercises using mannequins with virtual reality or standardized patients are used. This is useful to prepare the students before they start doing clinical postings on the real patients, so they have some kind of training before that, and this allows students to practice and refine their skills in controlled and safe environments. Mentorship and feedback, yes, again, very important component. Experienced clinicians mentor students, providing guidance and feedback. And this helps students learn from real cases and improve their clinical skills. And reflective practice, yeah, that's a very important attribute. When we reflect on our own experiences and we identify our own weaknesses or mistakes and then try to improve on that. So students are encouraged to reflect on their experiences, analyze their performance, and identify areas of improvement. And this self-assessment is an essential part of professional development as well. Then is the integration of theory and practice. The curriculum is designed to integrate theoretical knowledge with clinical practice, and we have seen so many examples we gave in the previous slides. Anatomy, pharmacology, and other basic sciences linked with the clinical sciences in different sessions. How we can deliver the integrated curriculum, we have joint sessions, which we have discussed quite in detail. We have PBL sessions, we have case-based learning sessions, we have themes, common lectures, symposia or webinars, early clinical exposure, assignments. That the assignment is that in such a way that different disciplines would be involved. So student has to go through different disciplines to complete that assignment. There may be projects or videos asking students to produce some videos which involves multiple disciplines. And then the vertical module. In our medical school, we have this personal and professional development and ethics module, which would run all the 5 years from year 1 to year 5 as a vertical module, and some degree of vertical integration was there. So these are the methods of how we can deliver the integrated curriculum. Means once we have identified the content, we have identified made the integrated timetable, and then we can use these methods to teach. Yes, Prof. Hamza. Yes, please.
Yes, Prof. Just came to my mind that that's yes, we are doing PBL, we are doing CBL, we are doing common lectures and symposia, these things.
Right.
Coming to the vertical modules, that's I want to really understand from your own experience or for some of our respected colleagues,
Right.
that how you do with the vertical, because our courses are all either it is semester based or the annual based, and we have to finish, students have to finish that course and they can go to the other. But how I try to do certain module like ethics or research vertical, but we could not do because of the regulation of our university. So how you do this vertical modules,
Right.
and
Okay.
when the assessment and so has been done?
Yeah, Prof. Let me share my own experience in that. We had this vertical module, which we would have, let's say, 2-hour session every week. So let's say Friday afternoon, we have fixed 2 hours for this PPD and E, which is personal professional development ethics. And so the different disciplines would be contributing in that. And so this would run vertically, and if possible, the topics would relate to the module which is running at that time, but it's not always possible. So it was not necessary. Sometimes the session of PPD and E would not be really in line what module was running, so that was acceptable, but we would try as much as possible. And then for assessment, we would have some questions about that in the end of module examination. So in that way, it would be assessed to some extent. But major assessment would be in the clinical years, where the ethics would come and professionalism would come, and that would make a major component. For example, in our OSCE or clinical examination, where there would be a lot of marks given to this area. If anybody else want to share that experience, that would be good. Yes, Dr. Ahmed, yes.
Thank you, sir. We have similar experience with you in the preclinical phase. We have some, committees. It takes 1 month or 40 days. They are, system-based committees, and we integrate the panels into those committees which are related to the committee's topic. For example, in cardiovascular committee, we assign a hypertension panel, where the physiology, pharmacology, cardiology, cardiovascular surgery, all of them comes together.
Right.
A few hours, 3 to 4 hours, and we discuss the topic together, starting from the physiology, ending with the pharmacology or something. And we try to increase the number of these panels in the committees. Every committee has a panel, but since it requires a organization of the professors bringing them together at the same time, it's not easy. So it has its limitations, but the evaluation is even harder because we take a small quiz at the end of the panel, but it's not included in the the main evaluation. The committee has its own evaluation and the exam. They're evaluated in the big exam, but as you told before, those benefits are evaluated in the clinical phase in the cardiology course.
Yeah, I agree with you that especially the common sessions which you mentioned about the vertical integration, it's not easy to organize. That's why we don't do it so often. Maybe once
Yeah,
a month.
we cannot.
Yeah, because obviously the clinicians are busy and it's not easy to bring them in. So we do it less frequently. Okay, Dr. Rohan, please. Yeah,
Sir, I want to ask a question from Dr. Ahmed.
right.
Actually, you told that during the hypertension panel, teachers from cardiology as well as CTBS is called upon to take the lecture, as you have mentioned right now. So during the UG curriculum, you are involving the teachers from cardiology and CTBS in the UG teaching. Hello.
Yes, Dr. Yeah,
Yes.
yeah. The question is, Dr. Rohan is asking that are you inviting these highly specialized people to teach the undergraduate students?
Yes. It is in the second grade and third grade, especially these panels are organized for those classes for the undergraduate students, and every specialist, every professor in the panel, they are listening the other ones' presentations as well, and sometimes they interrupt. They ask questions to other professors. So the interaction between the speakers is so important for the students. They observe how the professionals communicate and how they solve the conflicts and so on and so forth. So it is really valuable for us. Usually the professionals present the cases, not only the the theoretical information. They present the cases. They discuss with the other disciplines and so on and so forth. This is how we do it.
I think Dr. Rohan's concern was that you are inviting such highly qualified people to teach the undergraduate students, whether they can come to the level of these undergraduate students and
I
talk at
see.
their level. They may be talking with,
Sir,
but
my
obviously
concern
it depends upon the learning outcomes and how you brief them.
Yeah.
Actually,
Yeah,
my
it
concern
sometimes
was
can create
it is-
problems.
Actually, my concern was that this is a regular practice in PG teaching here. For the PG teaching, we regularly, because all the PG students, they have, like all the PG students of general medicine or medicine, they have postings in all these super specialty departments also. As well as they teachers, the special super specialty teacher, they usually teaches the postgraduate student. But in undergraduate student, this thing is only occasionally we usually do. Like super specialist doctors for the UG teaching, this is only occasional thing that we can do here, because all the teaching related to medicine, it will be conducted by only general medicine people here, not by the super specialists.
Dr. Rohan,
I see, but in Turkey's practice, even the first grade lectures related some topic. For example, we are talking about let's say hypertension. The cardiologists come the first graders to teach hypertension, not the general practitioners.
right. Before I invite Dr. Khalid for his comments, Dr. Rohan, do you use PGs to teach undergraduate students?
Not just for the practical purpose.
For
During the
practical?
clinical posting, not for the theoretical lectures.
Right. So for let's
I
say
see.
clinical skills or practicals, so postgraduate
They are
students can.
they are available for the practical teaching, even in
Right.
the preclinical also. The
Right.
PG students are regularly teaching the UG student only for the practical purpose.
Right.
But for theoretical purpose, only the faculty or consultants are involved.
All right. Okay. Okay, Dr. Adnan Khalid, please.
Sir, thank you. Regarding this issue of or the concept of undergrads being taught by subspecialists or super specialists, it is not only a matter of they taking out their time for this, but also not the fact that they can teach more than less because as teachers we want to tell them everything as we were pointing out earlier.
Yeah.
So is anybody thinking about the cognitive load that we're putting on our kids, on our learners? Basically. And plus, if they have major knowledge gaps, like they do not know general medicine, and we are talking them about taking deep into cardiology or cardiovascular surgery. So, is there any, would we really be benefiting at this such early level? Or maybe it should come at a time.
I think, Dr. Khalid, it's not the person. It's the what they are asked to do and what they are supposed to do. I know it's not easy to tame them down. I agree on that. But let's say we have specialists, but we have to tell them that you have to talk at this level. This is our learning outcome. So, but still, I agree that sometimes they would deviate from that. But like Dr. Rohan was saying that he thinks that mainly they should be teaching the postgraduate students, not undergraduate students. But if, let's say, you have these people around and they can help in teaching and they can follow the learning outcomes and talk at the student level, I think that should be okay. But of course, the reservations are there. Right, I think we should move further. So these are different delivery methods, and the methods of implementing vertical integration. One is themes. And in themes, there is a contribution by clinical lecturers, early clinical exposure, common session, interdisciplinary seminars, and longitudinal modules. These are different ways that we can implement the vertical integration. Now, here I'm giving you an example, which is integrated case-based learning. And this is example from Interprofessional. And purposely, I chose this because later on, I would request you to follow this, but change the different specialists or different disciplines with your own, let's say, physiology, anatomy, and see how it can work. But this basically, by giving this example and asking you to convert it into your own experience, I thought that would be useful rather than giving straight an example which is from your disciplines. So integrated case-based learning sessions are a great way to enhance collaboration and understanding among different healthcare disciplines. So here is an example of integrated case-based learning and the contents. So this integrated case-based learning is, this session is meant for medicine, dentistry, and pharmacy. When you want to change, you can change to physiology and pharmacology or pathology. But here I'm giving the example that it involves medicine, dentistry, and pharmacy. And the title of case-based learning is the Managing a Diabetic Patient with Periodontal Disease and Polypharmacy. So it's a patient with diabetes, has a dental problem and is on polypharmacy. The overall learning outcomes would be the participants would develop interdisciplinary collaboration and understanding in managing a complex patient with diabetes mellitus, periodontal disease, and multiple medications. The participants will gain a deeper understanding of how their respective fields contribute to the holistic management of a patient with multiple chronic conditions, fostering better communication and collaboration among healthcare professionals. These are the general or overarching learning outcomes. The case summary is that a 60-year-old male patient with a 15-year history of type 2 diabetes mellitus presents with worsening periodontitis. The patient is on multiple medications, including metformin, insulin, antihypertensives, and a statin. The patient complains of bleeding gums, difficulty in chewing, and recent episodes of hypoglycemia. So that's the case summary. Now, the specific learning outcomes. First, I was talking the general, the specific learning outcomes for medical students, for example, discuss the systemic implication of poorly controlled diabetes and its impact on oral health. Explain the importance of glycemic control in managing periodontal diseases, and review the management of diabetes in the context of potential drug interactions and adverse effects. So those would be the learning outcomes for medical students. Learning outcomes for dentistry students: explain the bidirectional relationship between diabetes and periodontal disease. Identify appropriate dental interventions and treatment planning for a diabetic patient, and discuss the impact of oral health on systemic conditions like diabetes. And then there would be learning outcomes for pharmacy, and the review the patient's current medications, potential drug interactions, and adverse effects. Assess the patient's medication adherence and potential barriers, and provide recommendations for managing polypharmacy in the context of diabetes and periodontal disease. So we saw that there is an overall or overarching learning outcomes which are broad and general. Then we have specific outcomes for medicine, dentistry, and pharmacy. And then the structure of the session is that in the first 10 minutes, there is a brief overview of the case by a facilitator, presentations of patient's history, current symptoms, and medication list. Then for next 40 minutes, the students go into their group, the medicine group, the dentistry group, and the pharmacy group, and they work on their learning outcomes, which I have just identified, like discuss the patient's diabetes management, focus on glycemic control, complications. So those specific, they work on those. Then they come back, and then another 30-minute session that each group presents their findings and recommendations. Then the whole group discusses the interplay between systemic health, oral health, and medication management. And whole group also develops a comprehensive interdisciplinary care plan for the patient. And then there is another 10-minute by the facilitator who summarizes the key learning points, highlights the importance of interdisciplinary collaboration in patient care, and addresses any remaining questions or concerns. So this is an example of an integrated case-based learning, but it is for interprofessional education. If we can use this to replace the let's say dentistry and pharmacy there, and let's say we put here medicine, surgery, or pharmacology, or we put pharmacology, anatomy, and physiology. So in that way, this example, we can extrapolate this to our situation. My purpose of giving this example was that just to think about it and see how it can be implemented in not interprofessional, but intraprofessional in our setup. Right. So we have mentioned that how we teach the integrated curriculum. Here is how we assess. We have modified essay questions, our problem management, patient management problems. We have problem-based questions. We have structured essay questions. We have extended matching questions, assignments, or assessment during problem-based learning sessions. Clinical exam is based on the logbooks and portfolios, OSCE, mini CX, mini clinical exercise. Some institutions may have a long case, a comprehensive long case, and a short case. So these could be the different assessment methods in an integrated module. Right. Any questions before we go on to our exercise? Okay, I think yes, sir.
So regarding this example of vertical integration of ethics and professionals module,
Right.
because I've seen that that is a module that we can very easily go for vertical integration.
Right.
As Dr. Professor Hamza also said, that how do we assess them longitudinally? Because we know that assessment drives learning. If something is not being assessed,
No, yeah, right. So what we do is that we include a component of in the end of module. You see, because modules are running, and then this is a vertical module as well. Let's say we have CVS module for 7 weeks. So there would maybe 5 or 7 sessions of this PPDE as well. So when we do the end of posting assessment, we include a component from this as well. So, and students know that this is one is component is from CBS and this portion is from this vertical module.
yes, sir. So there's another query regarding that how much of integration is possible in a module. Sometimes because I'm teaching first year surgery in modules.
Right.
We are practicing level 7. We are doing integrated sessions. But the thing is that it is not very easy to have logical sequencing most of the few times.
Right.
Because I think there's certain topics which are miscellaneous kind of stuff. They cannot be integrated. So we can, if we have 5-week module or a 7-week module, if we have 6 weeks or 5 weeks of integration and 1 to 2 weeks left for miscellaneous topics, is that a pragmatic
No,
approach or not?
I think that's fine. Even if you see the integrated module, there would be some topics which, for example, we are teaching research. And so whatever you are teaching about the research along the vertical module, that may not fit into that module exactly. And there would be some topics which you are absolutely right. So those miscellaneous topics, they can be taught wherever.
Like for example, in biochemistry, we were in respiratory module,
Right.
but the biochemistry didn't know how to cover the content of vitamins. So
Right.
they wanted to include vitamins in the respiratory module, and we had to allow for that because
Yeah,
if we are totally modular based,
I don't think that should be much issue. I mean, we have to cover, and some obviously we know that some topics may not fit, and so yeah, that's fine. That's fine as long as we are following the principle. Yes, Dr. Ahmad.
Thank you, sir. You mentioned about electronic portfolios, about assessing the clinical skills for integration modules. I'd like to make a collaboration offer for the medical education professionals here.
Right.
We developed a mobile application where you can track down your clinical students' clinical skills, and it is gathered in the electronic portfolio, and it is analyzed by AI, and it is giving feedback to the students and the professors, and you can analyze all the data together for the student and the faculty as well. It is a non-profit project for us, so we are looking for international partners to apply this mobile application in their medical schools, medical faculties. If anyone interested in tracking down clinical skills, and not only the clinical skills, but the attitudes of the students, like leadership, communication, and so on and so forth. If they can contact with me, I'd like to create a project and work with these high-end medical education professionals. Again, it will not cost anything to the faculties or the professors. We are just trying to extend internationally and analyze the results and compare the countries in this regard. Thank you.
I think that's fantastic. That's a very good offer. Only thing, the word track down is people may not like that they are being.
The name of the application is Skill Tracker. That's why I use track down. But give me just a few seconds more. When a student performs a clinical skills, the clinical skills are defined by the faculty in the application, and the steps are also defined beforehand. Learning objective of the faculty and is also connected with the skill beforehand. When the student perform the skill, students choose the skill in the course list and add some proof if they will, maybe the patient's information, the consent or something else. Send the responsible assistant or the professor. The professor gets a notification that the student performed the skill, and the professor is, checks down the items which the student did or did not, and right away the student gets the notification that the skill is approved, and it appears the electronic portfolio of the student, so it flows very quick and swiftly, and it reduces the paperwork all the way. So we are using it in 3 faculties in Turkey now already, in dentistry faculties and the medical schools as well. So we have over 1,000 students user already now, and it is expanding. And again, if anyone interested and want to be partner of the project, they can reach me out. Thank you.
All right, thank you very much. I think our WhatsApp group would be available even after this workshop, and we can continue our discussion on that. Maybe we should move to our activity now, but just one example. I think Dr. Rohan wrote me that he want an example of what in India they call as a linker case. So here, this is especially for on the request by Dr. Rohan. This is one case which we can use as a linker in undergraduate medical education. let's say Danish, an 11-month-old boy, is admitted to the pediatric ward of hospital with the complaints of diarrhea and vomiting of 2 days duration. On examination, he is drowsy and irritable and is unable to drink. His skin turgor is poor, which is more than 2 seconds. Eyes are sunken, anterior fontanelle is depressed, and mucous membranes are dry. His pulse is 130 beats per minute, weak but regular. Respiration is deep with a rate of 50 breaths per minute, and capillary refill time is 4 seconds. These are the results of investigation, arterial blood gas and serum electrolytes. And this can be a linker case where physiology, biochemistry, microbiology, pediatrics, and pharmacology can contribute. So we can basically some of your PBL triggers can also become the linker. Right now, I think what we will do is I will make this grouping, but in the meantime, maybe we can have you can have a 5-minute break while I'm making these groups. But you are already aware of this because I have sent through the WhatsApp. So just let's have a 5-minute break, and in that time I'll make these groups, and the tasks are there. And I think we would have around, let's say, how much time we can have is maybe around 15 minutes for you to think about it, and then identify one representative who would present the findings to the whole group. So let's say now, take just 5-minute break, and in the meantime, I will make these groups, and when you come back, you straight away join to these breakout rooms. Thank you.
Thank you, sir. It was very enlightening presentation.
All right, thank you. We will see during the activity as well, right?
Yeah, sure.
Okay. All right. Welcome back.
Thank you.
Yeah. Yeah. I think some of our participants could not join. Others, can you please switch on your cameras, please? Dr. Jamshed, yeah. Right. And I don't know who is the person with this Samsung, name of Samsung SM. Dr. Aisha Khalid, I think she's not there. Maybe we can share your experience, and the group 1 is Dr. Ahmad and Dr. Rohan. You can share your thoughts.
Sure, Dr. Ahmed will start.
Yeah, it was quite amazing experience. We worked really fast and tried to write down the plan. Thank you, Professor Rohin. Maybe he would like to share his experience.
Sure, sir. Sir, you please elaborate as we have discussed as well as written.
Okay. So can I start what we planned? Can
Right.
I?
You
Okay.
want, if you want to project, you can share the slides.
We couldn't prepare the slides.
Right, okay.
I took down few notes,
All right,
and
okay.
I'd like to share with you.
Right.
First, we started defining our learning outcomes, and we have defined them knowledge base, skill base, and effective base.
Yeah, just for everybody, this is about musculoskeletal module.
Yeah,
Right.
sorry. It was for musculoskeletal module. let me share a few learning outcome we defined. Describe the development, growth and microscopic anatomy and functions of musculoskeletal system. Explaining the physiology and pathophysiology of common fractures, dislocations, and arthritis. Relate the mechanism of action, the side effect drugs used, musculoskeletal diseases like pain relieval or muscle relaxants. Distinguish between the accidental and non-accidental traumatic bone lesions. This is for which department? Forensic medicine, because it is important to identify the abuse.
That's why actually I had included the forensic medicine in this group. Yeah.
That's a brilliant idea.
Yeah.
So these are few learning objectives that we had considering the departments in the module. And we had 3 teams. The first one is trauma and fractures. The second one, arthritis and inflammatory joint conditions. The third one is metabolic bone disease like osteoporosis. We included this one especially for the obstetric and gynecology. The first one, trauma and fractures, is the heart of the module because it includes all the departments, and I think the most important team is this one. In this team, surgery has management of open and closed fractures, soft tissue injuries, interpretation, imaging, trauma patients, choosing imaging types and prioritizing them and interpretation. For the anatomy department, bone, joint structures, ligaments, and upper and lower extremities. For the pharmacology, emergency pain management. Maybe it is important. Thank you for Professor Rohin, because pain management is very broad topic. Maybe it is important to distinguish between the general pain management and emergency pain management. And muscle relaxants in this pharmacology section. For forensic medicine, interpretation of fractures in forensic medicine to identify child abuse, and defining a mechanism of trauma. And of course, after the trauma, forensic medicine can include that analysis and identify the reason of that. Obstetric and gynecology, pelvic trauma may be one of the topics, and pregnancy-associated osteoporosis is one of the other topics. We had, other teams for arthritis and inflammatory joint conditions and metabolic bone disease, but we don't want to take too much time. But it is we identified for each one. Then we now have our learning objectives and our teams and team related content. Now we have to decide teaching and assessment methods. For the teaching sessions, we thought we can have classical didactic lectures, also joint sessions, which has a linker case in it. So all the departments can join the joint session. Case-based learning, we can use case-based learning. And also we thought that we should include early clinical exposure, and we thought that we can send the students where the trauma patients located, for example, emergency medicine or orthopedic service and other places. Then they can come back and present their patients. So
As well as bedside teaching
yeah,
to also
bedside
be present.
teaching, and after for the assessment, they can come back and present their patients. So we also include early clinical exposure. For the assessments, we thought we can, we can have a multi-choice exam, but it is more important to have a simulated patient followed by an OSCE exam, and also we can give some multidisciplinary task to the students. They can make their research and present them. Also, they can present the patients they have seen on site, on bedside. They can come back and present them to the fellow students. And then after, the only thing we left is create a teaching plan and timetable, and we can organize it accordingly. But as we told, I think the first team, trauma and fractures, should take a bigger volume in the course. But when we organize our timetable, I think we're good to go to teach students. Professor Rohin, is there anything you can add? Or
I think
I'd like
you
to
have
take.
beautifully explained the whole of the things. And
Thank you. I'd like to thank Professor
basically, we
Rohin.
will basically according to the theme, we will stress upon the main theme will be skeletal trauma or polytrauma, because forensic people is involved as well as given in the participating department. That's why the main theme will be polytrauma or skeletal trauma. Others themes were selected because of ops gynae people. Because as the participating department is given, as well as we have.
Maybe we should get comments from the other team.
Sure, sir.
Jamshed,
They are
you
welcome, sir.
want to comment?
Yes, thank you very much for giving me a chance. Actually, this is very extensive, very good module that heard. All the aspect has been covered. Professionalism, skills, knowledge, everything is. I want one thing for improvement. That what was the preceding module? What will the next module? Each and everything has not to be covered in a single module. Left it for the other modules also. Very crisp, concise. Should be very crisp, concise. And it should be covered within the given time.
No, actually, Dr. Jamshed, we had a very interesting exercise. When we were developing this curriculum in one of the university, for every module, we didn't fix the time. We said, okay, we had team for different modules. We said, okay, you come up with the content, come up with the theme, and then based on that, we will allocate the time. Because, right? And so it was really, really interesting that we didn't have any shortage of time. What happened is that when the team came up with the content, and then we had a vetting, and we finally agreed with the content, and we were very, very easily fit into the time available. In fact, we had some extra time because we were avoiding the redundancies, we were avoiding the repetitions, and time was no issue. So yeah, because sometimes when you fix the time, the people feel that they are being restricted. So we said, okay, you have enough, not whatever time you want, you have it. Just come up with the content and see how much time is needed. I thought in that exercise that CNS would take the maximum time, but actually even we had extra time for the CNS module. So you do it, and it's so interesting. So that we gave them free time, and we could fit it so nicely.
Sir, one comment I want to say here,
Yeah.
according to Dr. Jamshed comment,
Yeah.
actually, sir, the module that we have prepared here, that is our final year MBBS student, final year. Actually, what thing we follow here, like this is a musculoskeletal module. The theme was trauma. So exactly the same thing we usually follow here in India. We use the task based, like trauma is a task for us. So that thing we use in the clinical years, final years for people. Before that, in the second year or some point of time in first year, we usually do disease based. Usually use the integrated session on the disease based. But for few things that are very common, like tuberculosis, that is very common. So for tuberculosis task, we conduct an integrated session in the second year. Again, it is repeated in third year or final year. But the thing that changes is when we conducting the second year on the tuberculosis, the major participating departments are second year departments, few insights from the first year, and few insight or very less time from the third year people, final year people. When again the tuberculosis is conducted in the final year, then again a very few insight will be taken from the first year and second year. Major portion will be dealt by the medicine, surgery, obs-gynae, and pediatric people. So we usually do integrated session on the same topic by 2 times. On the second year as well as third year.
Dr. Rohan, I think what the two more things which you could have included is, one is radiology.
That is a part. That is a part of
radiology is very important.
That is a allied subject of surgery.
In
Surgery,
musculoskeletal,
orthopedics, and radiology we conduct.
And also some components of pathology. And the bone healing and all those things might be included. Right. Let's move on to the second group, which is cardiovascular. And I purposely put ophthalmologist in in this module because I thought they would like to see the eye changes during, let's say, hypertension and other things. So in cardiovascular module, these things should be covered, related. And that was, I thought that ophthalmology should be part of CBS module. So let's see what you have discussed. Can any one of you can present?
Yes, Dr. Salim, you're coming?
Yes.
Yes, Dr. Salim Adil. Yes.
First of all, learning outcomes.
Right.
So if anyone from a group can add something good, welcome. First of all, describe cardiovascular anatomy, the structure.
Sir, we are not able to see your slides.
अच्छा अभी स्लाइड ये स्लाइड में नहीं लिखा हुआ ये ज़बानी स्लाइड्स आगे आ रही हैं.
All right. Okay.
Visible.
All right. Okay. Yes. No.
So first of all, the lung objective is describe cardiovascular structure and understand its physiology, cardiac cycle, and then manifestation of common heart diseases, and then risk factor and preventive strategies against heart diseases. Yes. So this is about the anatomy, structure basis for the cardiovascular system.
स्लाइड शो पे कर लेंगे तो ज्यादा अच्छा है.
जी स्लाइड पे नजर आ रही स्लाइड?
Yes.
स्लाइड शो पे कर लेंगे.
Yeah, we can see that. Yeah.
Can you see that? Okay. So,
Yes, sir.
Yeah.
The circulation of cardiovascular system, just gross anatomy of heart, great vessels and pericardium, chambers, valves, and coronary circulation, physiology of cardiac muscles and blood vessels. Then function, cardiac muscle properties. Yes, and cardiac cycle and heart sounds, cardiac output and its regulations, electrical of the heart, action potential, ECG basics, blood pressure and its control, microcirculation and capillary exchange. So then biochemical basis and biochemistry, that's molecular and biochemical basis, that includes energy metabolism of cardiac muscles, role of electrolytes in cardiac function, lipoproteins and their roles in atherosclerosis, and then cardiac biomarkers, and then is pathology, which includes atherosclerosis, IST, and since we are teaching this first year medical students, so and then in medicine, introduction and early clinical correlation, that includes introduction to common cardiovascular diseases, only at an overview level, and then principles of blood pressure measurement, introduction to ECG in diagnosis, and then in ophthalmology, ocular manifestations of cardiovascular problems. Anyone wants to add something to it?
Okay, let's see the other people's comments, other participant comments.
Then is community medicine and preventive and public health perspectives. So that's burden of cardiovascular diseases and modifiable and non-modifiable risk factors, role of lifestyle in preventing cardiovascular problems, and health promotion and primary prevention in community against CVS diseases.
Right.
Anybody wants to add something?
Okay.
Thank you, Dr. Adil, for.
Can you stop sharing? Can you stop sharing? Okay, let's see the comments from other participants.
Thank you very much, Dr. Salim. Very crisply presented. Sir, I had while developing or thinking of such modules, when we name a module, we name a module according to the region or the system. So this is a system-based module. So my concept is that for two-dimensional integration or the vertical integration, I think we should have the CBS module in each year with varying representation from all the subjects and starting from first year till final year. And this is how we can actually do because having only horizontal integration and thinking of a module in terms of, so there's a lot to cover in CBS module over 5 years. So the first year we'll have stress upon the basics, but we will touch upon radiology. So if just say not the time would not be a whole lecture or 40 minutes, just mention it. Then we'll have to decide who will mention it. That in X-ray we see cardiomegaly or something like this. So the problem is that sometimes I face is that how to cover each content, who should cover it and for how much time. Like for example, in say in radiology, for example, I have to say what is an echo. So in first year I just mentioned there is an echo. It's a motion mode ultrasound, that's all. But as the years progress, in each year we'll have the same module with varying proportion, overall time, overall duration, and varying degrees of time given to each and every specialty. And giving time to each and every specialty doesn't always mean that the person from that specialty has to come and teach. These are my few queries that I wanted.
Not necessary. Not necessary. Yeah, I mean our aim is to cover that content. So if a non-specialist can cover that content, that should be okay. It's undergraduate medical education. So let's say if, for example, something about pharmacology and the pharmacologist is not available, but some other person can, let's say medicine can cover, that should be okay. It's not necessary for the specialist to really be there all the time, but if somebody else can cover that, that should be fine.
Sir, while transitioning from traditional medical schooling to this integrated, I found this division of it's very arbitrary that primary subjects for the year, or maybe the secondary, those which are examination subjects, the one who are for which they are going to appear in their professional exams, and the other subjects which are not going to be covered in the end of course or the high stake exams of the professionals. So here the more time should be given as we are in third year and fourth year, maybe more time would be given to pathology and pathophysiology for the CVS module. And as we progress further to clinical years and clerkships, the whole time would be given most of the time. But anatomy would stay there as a remembrance or as a reminder. And that anatomy could be taught not by the anatomist but by the surgeon. And similarly, so this is maybe we can actually
Yeah,
make
yeah.
it.
I mean, the surgeon teaching the anatomy would be more sort of clinical related, whereas anatomist may be more towards the basic sciences. But as I said, it all depends on the learning outcome. The one you see, we have given some learning outcome of CBS module in our presentation. If somebody want to look at it for each learning outcome, you identify the content which would be needed to cover that learning outcome. So let's say this is first learning outcome, and these are the topics which are necessary to cover this. This is second learning outcome, and this is these are the topics necessary to cover. And then you can arrange it under themes. But the whole thing is that don't feel restricted. Don't feel restricted. Something may not fit. It's all right. We are not looking for sort of 100% fit there. As long as the principle is there and the things are there, one or two topics here and there shouldn't be a big issue.
Yeah, I want to have a comment. You should know the level of the learner. No? That's why you have to be restricted.
Right.
What to teach at what level to what kind of a student is the basic.
That I agree. That I agree, because our only restriction is learning outcome. Learning outcome draws a boundary for us. So we have to stay within that boundary. And that's why we were, there was a comment that it's important to know what to teach, but it is equally important to know what not to teach. So we have to stay within the boundary of that. Yes, Dr. Rohan, please.
Sir, I have comment regarding the query raised by the Dr. Adnan. Actually, sir, you have said that like completely integrated session, completely integrated curriculum. What we are practicing here, that integration has two aspects, horizontal and vertical. What we are stressing here, that it should be completely horizontal integration. That can be done very easily. That is horizontal integration. It is very much possible, because all what thing I have to done that in one curriculum year, in one professional year, all the teachers are like first year anatomy, physiology, biochemistry, they have to sit one time and they have to prepare their academic calendar according to that same time. When I am teaching the CVS, physiology is also teaching the CVS. I have to prepare only one time my academic calendar, and that can be followed every year. So 100% horizontal integration can be possible.
Yep.
Regarding the vertical integration, what we are taught that only 20% should be the vertical integration, 80% time should be devoted to the subject-based teaching. Like in integrated session, like you are teaching the CVS module. But for a medicine people, if he is teaching the CVS, he requires at least 10 to 12 hours of teaching.
Yep.
Only of the CVS, but an integrated session, 10 to 12 hours of teaching of a medicine people only is not possible. He's just taking a small aspect of CVS in that integrated session, but 10 to 12 hours of subject-based teaching of medicine, that is separate thing. He's doing
Dr.
in
Rohin,
80% of time.
I have two comments on this. First, you are absolutely right. The contribution of clinicals in the basic sciences is limited to the theme. Like we were saying, the theme of the week is myocardial infarction. So a physician can come and show some cases and some, the information about that, mainly to increase the student interest in that, right? And you remember the picture I showed you, that I think fifth or sixth slide, where there is a horizontal line with the and it shows that how gradually the clinical input increases and the gradual the basic sciences input decreases. So we have to keep that balance. We cannot be teaching the full medicine in preclinical years. It's one or two sessions only related to the theme. And the other vertical integration is mainly through PBL sessions, mainly through common sessions. That would be the, I think, the approach. Yes, Dr. Ahmad, please.
Sir, we are focused on mainly about knowledge and skills, but vertical integration has another benefits, like when first or second grade student exposed a clinician, it would make him or her feel more like a medical doctor. It would motivate and give him some sort of belonging feeling to the faculty. It is not only about the knowledge they can transfer from the clinic to the basic science or preclinic, but also the attitudes, how they speak, how they walk, talk. Everything is really important for the medical students. When you isolate them in the preclinic years, they don't feel themselves as a medical doctor and belong to the faculty. That's why it's really important to bring the clinicians in the preclinic years, and also important that they are also frustrated. We shouldn't overwhelm them to make them teach some theoretical things as well. I think the information they were focusing should be the medical cases, their experience in the faculty or the hospital, and that's why it's important to create upside down the classes, make the students study the theoretical things at home and exposed to the professors at the school with the experience, with the cases, and so on and so forth.
Yeah,
that's really important.
That's the concept of flipped classroom.
Yeah.
Right. And there's one more advantage. The clinicians always grumble that these preclinical students don't know anything. I don't know what they were taught in the preclinical years, but once they are involved in teaching, probably they would stop complaining.
Exactly.
Yes, Dr. Adnan, yes.
So regarding this, Dr. Rohit was making the point, he's very right. But we should not think that one-dimensional integration or the horizontal integration is the end of the story, and they are two separate. Horizontal integration is a composite factor, is a composite phenomenon. It's not that we do horizontal integration, vertical. Once we are doing two-dimensional or vertical integration, we are actually doing horizontal integration and vertical integration. So we are doing both. It doesn't mean that we are not doing this. And the other thing is that actually now people are going beyond vertical interview with a broader concept. And I've shared an article with the chat box, and it's in article 2020, and it says that now they are thinking of and trying to involve undergrad medical students, giving them micro responsibilities about their patients in the clinics. So they are making the students are being made responsible for a certain aspect of their patient care, so that the transition from medical graduate to the house officer also becomes relatively easier.
Right.
So I think the thing is that the best thing is to integrate is to how to do it physically. Sometimes what happens is we have dedicated so many hours. Like for example, in our setup, we have 40 hours of surgery in first year.
Mhm.
So how do I go about taking out those 40 hours? Is basically I try to follow the primary subjects. I logically sequence my lectures or my interactions, large group interactions, sequencing them after what has been taught to them in anatomy and physiology. And the thing is that I do not tell them what to teach, what not to teach, the anatomy and the physiology. But sometimes I feel that you see the aim, we must remember the outcome that we're trying to achieve. We're trying to achieve safe house officer. We're not trying to make anatomists or biochemists. But the thing is that this needs to be redefined. The faculty members sitting together and redefining what really is important. You very rightly said that everything revolves around learning outcomes. So, what should be the primary determinant of a learning outcome? What should decide what a learning outcome should be? My impression is that it should be the burden of the disease or the clinical question or whatever is prevalent
I
clinically,
think,
patient
Dr.
problem.
Khalid, it should be the house officer. It should
So,
be the top-down approach. What we do is that what do we expect from our graduate when they enter the hospital as a house officer, and from there we trickle down the knowledge, skills, and attitude, etc. I think we are already 20 minutes more over time. Enthusiasm is there, and but I really enjoyed the session. I hope you also did that.
agreed, sir.
We will have our WhatsApp group, and please do share. Maybe Dr. Khalid, you can share again your article, the one you are mentioning in the WhatsApp group as well,
We
because
do that, sir.
because some of them the participant couldn't join today. And Dr. Ahmad is going to tell us more about the mobile application, and we'll
Looking
see.
forward to that, sir.
Yeah, right. And yeah, unfortunately, I have to close close the session. I really thank everybody for your participation. And honestly, we learn from each other. And after every workshop, I leave as a wiser person than before. I always learn something new. Although on paper I'm supposed to so-called teach, but in fact, I learn from that. And thank you very much, everybody. And hopefully we will see each other again sometime.
Inshallah.
I request
Inshallah.
one more request, sir.
Thank you very much, sir. Thank you
Inshallah,
very much.
sir. Inshallah.
Dr.
Thank you very much, sir.
Dr. Rohan want to say something.
My request is to kindly send me that reference material of 113 clinical cases as well as 120 of
Yeah,
Aga Khan,
yeah.
so that I can study more regarding that.
If I don't send, please remind me. I'm an old
Sure.
person and I can
Okay.
forget it
No, yes, I will-
easily. Yeah. Right.
I will-
Okay. Thank you very much, everybody.
Thank you, sir.
Thank you, sir. Thank you, sir.
Allah Hafiz, sir. Allah Hafiz, sir.
Allah Hafiz, sir.
Allah
Allah
Hafiz.
Allah Hafiz.